Okay, so pulmonary emboli, they are a blood clot in the lung, or any kind of blockage of an artery in the actual lung. It's usually caused by a clot, I guess I should say that. And it travels through the bloodstream and it just kind of sets in our lungs. Remember, this is the famous ways that DVTs actually break off, and DVTs are famous for going straight to the actual lungs. Right around 50,000 deaths per year, and about 5% of these are sudden deaths. And 10% of all the actual PEs will actually result in death, period. Um, Again, we're going to talk about the causes of this, the pathophys, and some of the risk factors coming up. So, one of the biggest risk factors, like I said before, is the actual. Excuse me, I guess I'm going to drink. One of the biggest risk factors that we see this in is usually when we develop a blood clot in a deep vein, usually of the leg or the actual pelvis region. And this clot develops because of all the atherosclerosis. That clot will actually break off, or it can break off into numerous pieces, and then it kind of gets lodged into the actual capillaries of the lungs, which will actually cause the actual PE. Any kind of prolonged bed rest, usually like during a serious illness. That's why it's important for our colleagues in the nursing homes and in the hospitals to make sure that they're turning their patients as much as possible so that we don't get bed sores and we don't actually develop clots that can actually go and lodge into our lungs, heart, or brain, right? Major surgeries, okay? And I'm talking like not necessarily recent surgeries, right? Anywhere to about 6 to 8 weeks out of surgery, usually is when we're actually kind of seeing these actual PEs, if we're thinking it's a PE after a surgical event. And again, usually this is surgeries that are performed on any kind of long bone that didn't get adequate coagulation while the actual surgery was taking place. So any kind of long bone, like the pelvis, knee replacement's huge for these tib-fib fractures, femurs for sure, right? Anything that any kind of long bone like that. Heart surgeries are also a big component of these as well. Um, any kind of fractures to the hip or the thigh bone, heart attacks and stroke. Certain blood disorders can cause PEs. Long trips, especially long trips at altitude. Long trips at altitude, specifically like long trips on a plane, can really cause blood clots. Anytime a female gets pregnant, their clotting factors go through the roof, and birth control pills as well can cause an increase in clotting factors, and smoking. Um, um, Smoking can also cause some kind of clot in the lung and an actual air emboli, something that we can cause. And I'm sorry, I forgot to put emboli on the actual slide there. It's not just air. Air itself cannot cause a PE. Don't freak out, guys. But an air embolism for sure is right. If we don't prime our IV lines accordingly, if we're just being reckless with the way we're doing our actual IV procedure. This can also be because maybe we have somebody that suffered a neck injury, and possibly because of all the actual sizes of the vessels in our neck, if one of those gets severed, they can actually suck air in to one of their veins or their arteries through the neck if it did have some kind of like laceration or something like that too. So these are all kinds of risk factors that could be um, um, these are all kinds of risk factors for the actual PE itself. So again, the pathophys is this is one of these risk factors are in play, and just that clot has developed, and it just kind of lodges in the lungs, and it prevents the blood flow to that area, and it restricts external respiration. This is probably the only true VQ mismatch that you guys have as a disease process. This has both components of both the ventilation and perfusion portions of the VQ mismatch. And again, the big culprit here is the actual deep vein thrombosis, or the DVT, that's found in the leg, and it just happens to break off and travel to your lung. So I'm kind of nerdy with this. I broke it down into small and large emboli signs and symptoms, but you guys can basically put these two lists together because these are the signs and symptoms. However, usually when it's just a small emboli, we're going to have that rapid onset of shortness of breath, and we're going to have a persistent hypoxia due to it as well. Because of the clot, our ventilatory rate's going to rise. So naturally, for our body to compensate, our heart rate's going to rise. We'd have to consider this for anybody that actually has a history of thrombophlebitis. And we're really going to consider this very, very early in our diagnosis, when there really is no cardiorespiratory diagnosis that matches the story of the patient. Okay, this whole diagnosis is really, or at least our quote-unquote diagnosis in EMS, is really based on the history that you guys get on your patient. Once we kind of get up to the actual bigger size emboli, we're going to have all the actual signs and symptoms from the small emboli, followed by pleuritic chest pain. And remember that this is a pinpoint pleuritic chest pain. They can literally point exactly where it is in their lung where they're actually feeling this pain, and usually there's no radiation for this disease process. We could develop a pleural rub. That area of the lung is not being perfused accordingly. We are starting to kind of dry out the actual pleural sac, and that can actually start rubbing up against the inside of our chest cavity, which can eventually lead to a hole in the lung. Kind of a persistent dry cough. It's not really going to sound too wet. I mean, if it's very far in the disease process, it can sound wet, but usually it's just a dry, persistent cough that people are complaining about. We could hear wheezing as well, and we're going to treat that wheezing accordingly. They could be coughing up blood, but it is very rare for them to do that. It's a pretty large emboli, and more than likely your patient's severely circling the toilet. If we do have coughing up blood. End tidal, remember, end tidal is going to be persistently lower, right around less than 35, okay? Usually, I think a good pinpoint, if we had to put a number on it for you guys, it's usually right around the mid-20s. And then the oxygen saturation for our patients will continue to stay low or right around the same no matter how much oxygen we are giving them. And remember, this is due to the fact that we're not able to diffuse the actual oxygen due to the blood clot that's actually in the lung. And then we have the rock star, also known as the saddle PE. This is extremely large, and you guys have a video of that. I'm pretty sure I posted the video of that, I believe, in your anatomy and physiology lecture, of a removal of an actual saddle PE, where they actually went in and had to surgically remove this. This is all the signs and symptoms, and this is going to include central consistent chest pain at this point. They're going to have distended neck veins, and I'm talking wicked distended neck veins. This is going to be an acute onset of right-sided heart failure, so they're going to be actually having, they could actually have edema down in their lower extremities. This is going to very quickly lead into shock syndromes and more than likely cardiac arrest if this is not surgically repaired pretty quick. Okay, so for your pre-hospital treatment, I did skip a side. I want to make sure that you guys are looking at your respiratory guidelines, so I'm not going to lecture on it. Make sure you guys are looking towards your respiratory guidelines for the treatment of this. However, in the hospital, they're going to try thrombolytics. Okay, you have some examples of some thrombolytics there. I'm not going to go through each one of those. Or they could also try some anticoagulants. Really, just some heparin or possibly some warfarin seems to be the anticoagulants of choice for the hospitals. And then, if they really need to, they're going to go in there and they're actually going to surgically remove the actual clot from the lung.